A very good morning to all of you. And after the Diwali, we are meeting for the teaching class. Wishing you all a very happy Diwali from the Department of Urology, Savai Man Singh Medical College, Jaipur. Today we have a class on neurogenic bladder, its pathophysiology and evaluation. This will be presented by our resident, Dr. Ashok, and would be moderated by our faculty, Dr. Kuldeep. So I would request Dr. Ashok to kindly share his presentation. Okay. Yes, sir.
Good morning all. My topic is pathophysiology and evaluation of neurogenic bladder. Introduction. Definition of neurogenic bladder refer to dysfunction of the urinary bladder due to disease of the central nervous system or peripheral nerves involving in the control of micturition. Non-neurogenic bladder refer to dysfunction of the urinary bladder due to dynamic disturbance of genitourinary system. Complaints about urinary function are more common in patients with neurological disease. 98% of lifetime bladder is in storage phase. Development in childs and adults. In 1 to 2 year conscious sensation of bladder fullness develop. In 2 to 3 year ability to initiate or inhibit voiding voluntary develop. 2 to 4 year voiding come under reliable voluntary control. By the age of 4 year micturition spinal reflex fully modulated by CNS micturition center. Why we need innervation for bladder? Urine is produced at the rate of 0.3 ml per second, but emptying is intermittent. So urine has to be stored. It has to be under low pressure to prevent reflex. It has to be coordinated between body and base. Structure in our bladder wall receptor, sacral center, afferent and efferent nerve, external sphincter, mediolateral gray sympathetic chain, PAG, Barrington nucleus, here are central lobule and prefrontal regions. Cortical center for micturition is frontal lobe and which is inhibitory signals syntonically. Pons PMC center, Pontine micturition center is excitatory center, coordinate between sphincter and the bladder affected by emotions. Bladder innervation is afferent and in afferent parasympathetic nerve S2, 3, 4 via pudendal nerve enter through posterior rami and terminate in anterolateral column, and sympathetic chain T10 to L2 via apogastric plexus enter through posterior rami and terminate in anterior medial column. In afferent innervation, parasympathetic S2, 3, 4 via pelvic plexus, and in sympathetic T10 to L2 via hypogastric and pelvic plexus. Voiding is initiated by pelvic nerve through detrusor muscle contraction and internal sphincter relaxation via parasympathetic S2, 3, 4. Sympathetic function is storage via detrusor muscle relaxation and internal sphincter contraction through hypogastric nerve. Etiology: suprapontine causes stroke, traumatic brain injury, degeneration, Parkinson disease, Alzheimer disease, dementia with Lewy bodies, hydrocephalus, normal pressure hydrocephalus, cerebral palsy, neoplasm. Infrapontine cause: demyelination, multiple sclerosis, transverse myelitis, NMOSD, trauma, spinal cord injury, vascular arteriovenous malformation, spinal cord infarction, neoplasm, metastasis or primary, hereditary spastic paraparesis, infection HTLV1. Intrasacral causes: spina bifida, intervertebral disc prolapse, arachnoiditis, diabetes mellitus, pelvic surgery with nerve injury. Micturition reflex: sensory signal from the bladder stretch reflex stretch receptor as conducted to the sacral segment of the cord through the pelvic nerve and then reflexly back again to bladder through the parasympathetic nerve fiber by the way of these same nerve. Sacral effects center is the primary voiding center in animals. Ability of brain to control the PMC is part of social training that children experience during growth. Afferent and efferent pathway showing through bladder wall stretch receptor through stretch receptor sensory fiber going spinal cord to PMC and frontal part and then parasympathetic come back to bladder wall and sphincter. Phases micturition is considered as having two phases: the filling storage phase and emptying voiding phase, and a sacral voiding through conus medullaris. Storage phase. In storage phase, no neural bladder control needed to storage. Storage in the phase of distension or pain required neural inhibition of voiding. In voiding phase, entirely under the control of neural control. Unlike storage, signal to initiate voiding come from the bladder is okayed by the frontal cortex, triggered by horns, and executed by sacral cord. Lepidase classification: motor paralytic bladder, sensory neurogenic bladder, atonic bladder, autonomous bladder, and uninhibited neurogenic bladder. Motor paralytic bladder: destruction of parasympathetic motor innervation, normal sensation of bladder filling, but is unable to generate detrusor pressure sufficient to empty the bladder. Symptom range from painful urinary retention to only a relative inability to initiate and maintain normal micturition. Sensory neurogenic bladder: selective interruption of sensory fiber between the bladder and spinal cord or the afferent tract to the brain. Loss of sensation allow for the bladder to distension without triggering a reflex bladder contraction. Uninhibited neurogenic bladder: disruption leading to the corticoregulatory tract over facilitation of the micturition reflex. Frequency, urgency, and urge incontinence. Autonomic bladder: interruption between the sacral spinal cord and the brain stem. No bladder sensation and there is inability to initiate voluntary micturition. Incontinence without sensation generally result from low volume involuntary contraction. Atonic bladder: complete motor and sensory separation of the bladder from the sacral spinal cord. Disease that destroy the sacral cord and causes extensive damage to the sacral root or pelvic nerve. Only bladder wall receptor are there. Large bladder with no sensation and continue dribbling. Low pressure filling and reflex. There is four scenario in bladder: good bladder with good sphincter and bad sphincter, bad bladder with good sphincter and bad sphincter. Evaluation of bladder dysfunction. History taking home the cornerstone of evaluation should assess both the storage and voiding phases of micturition. Important also to inquiry about bladder gynecological and sexual function as they often coexist. Medication history should also be important. Opioid, anticholinergic properties, antipsychotic drug, and antidepressant drugs. Storage dysfunction. Frequency for micturition, nocturia, urgency or incontinence. Voiding dysfunction, hesitancy for micturition, a slow and interrupted urinary stream, the need to strain to pass urine, and double voiding, complete urinary retention. Physical examination critical in deciding whether a patient urogenital complaint are neurological in origin or not. Bladder disturbance generally has been shown to correlated with lower limb deficiency. Exception: lesion of the conus medullaris and coda equina, where finding may be confined to saddle anesthesia and absence of sacral cord mediated reflex such as the anal reflex and bulbocavernous reflex. CNS examination also very important. Paraparesis in impaired deep tendon reflex in lower limbs. Peripheral neuropathy. Assess urogenital sensation. Sacral cord mediated reflex. BCR and anal reflex. Inspection of lumbosacral spine. In local examination, bladder distension, suprapubic tenderness in overflow incontinence. In rectal examination, prostate impacted soil, anal sphincter tone, and squeeze response. functional assessment of mobility to go to toilet and dexterity to remove cloth. Bladder diary. Supplement the history taking, record the frequency for micturition, volume voided, episode for incontinence, and fluid intake over the course of a few days. Provide a real-time objective patient-reported measure of a lower urinary tract symptom which might not be obtained through history taking or questionnaire. In bladder diary, at least 70 to 4 hours is required. It included date and time of void, urinary volume, drinking volume, and a type of fluid intake, leakage, any urge associated. Laboratory testing, blood urea nitrogen, serum creatinine, urine routine, urine culture and sensitivity, serum electrolyte. Imaging studies, low in your urinary tract imaging, cystourethrogram and direct visualization by cystoscopy. In upper urinary tract imaging, ultrasound, IVP, CT, MRI of spine, and isotope scan. Bladder scan PVR. Extent of incomplete bladder emptying cannot be predicted from history or clinical examination. Through USC portable bladder scanner or by catheterization in CIC patient of a neurogenic bladder, done within 5 minutes of intentional voiding. More than 100 ml is significant. Single measurement of not representative and if possible, a series of measurements should be taken over the course of 1 to 2 weeks. Raise PVR volume suggestive voiding dysfunction. However, it cannot be used to discern whether this is caused by poor detrusor contractibility or by obstruction for which urodynamic would be required. Ultrasound scan. Patient known to be at the risk of a upper tract disease performed periodically at least every 6 months to evaluate any renal scarring or damage in upper urinary tract such as dilatation. Also detect a complication of neurogenic bladder such as bladder stone. Bladder detrusal wall thickening and ultrasound estimate bladder weight are being investigated as known as the alternate to assess neurogenic dysfunction but are not yet established diagnostic option. Urodynamic studies, including uroplometry, filling and voiding cystometry, electrobiography of external sphincter, assessment of postvoidal residue. Uroplometry is a simple non-invasive test used for measurement of volume of urine voided per unit time. Flow depend on two factors: contractibility, the volume will be at least 130 to 150 ml in less than 700 ml to produce accurate curve. Normal Qmax in young male less than 40 year is more than 25 ml per second, and in females Qmax should be 5 to 10 ml per second more than male at the given bladder volume. Uroplometry should be done before any treatment and can be used to monitor treatment outcome. Privacy is essential and a spurious result may be obtained if the subject is fully not relaxed. Significant neurological bladder disorder is unlikely if patient has good bladder capacity and normal urine flow rate and empties to completion. This is normal uroplometry curve is bell shape and Qmax is should be reached in first third of the phase and a sharp cut off that at the end. Continuous flow patterns. A is compressive pattern seen in benign prostatic hyperplasia. B is a constrictive pattern seen in urethral stricture. C is detrusor overactivity and D is detrusor underactivity. In intermediate flow curve, A is a detrusor sphincter dysenergia. B is Valsalva voiding curve. Normal bell shape curve and artifact may cause high Qmax with poor flow. A is interpreted curve with low Qmax with intermittent flow and stop-start, suggestive of low total contractility with the abdominal stretching. In B, the curve is plateau of a stincture urethra showing low Qmax and prolonged voiding. Cystometry. Cystometry is the measurement of bladder volume and intravesical pressure during filling and storage phase of the for the purpose of evaluating detrusor function. Normal adult volume 400 to 750 ml, maximum bladder pressure of 15 mm water, storage phase intravesical pressure exceeding 15 centimeter of water, and a steep rising curve in cystourethrogram, possibility due to bladder inflammation, fibrosis, or detrusor hypertrophy. In voiding phase, involuntary detrusor contraction, that is, a phasing increase in intravesical pressure during the filling phase, reflects the presence of detrusor hyperinflexia and absence of contraction during attempt to void a reflexive bladder. Showing UDS study. Video cystometry give additional information about morphological change that are consequent to neurological bladder dysfunction in the presence of a vesico-ureteric reflex. Opportunity to inspect the outflow tract during voiding is of great value in patient with suspected obstruction, valuable in demonstrating the underlying pathophysiology of a patient's urinary tract, provide information about the safety and efficacy of bladder feeding and emptying, valuable for assessing risk factor for upper urinary tract damage and planning management, helpful in identifying concomitant urological conditions such as bladder outflow obstruction or stress incontinence. Indication: spinal cord injury, spina bifida, advanced multiple sclerosis, significant risk of upper tract involvement and renal impairment, valuable for demonstrating the underlying pathophysiology of LUTs, detecting risk factor for upper urinary tract damage in planning management. Other conditions such as early multiple sclerosis, stroke, and Parkinson disease. Some authors have recommended to restrict the initial evaluation to non-invasive tests. Risk for upper urinary tract damage is less. Electromyography. Sphincter electromyography record bioelectric potential during bladder filling, storage, and micturition. Voluntary control of pelvic floor musculature and coordination between the detrusor and pelvic floor during bladder filling. EMG activity should gradually increase and reach to a maximum before voiding. Prostrated sphincter dysenergy occur only in patients with neurological disease or injury at the level of spinal cord and represent voluntary sphincter contraction at the time of detrusor contraction. Detrusor sphincter dysenergy occur in patient with the supraspinal injury and is caused by interruption of the spinobulbar spinal pathway and provide coordinated voiding. EMG activity in infants and adults showing start and stop in paralytic bladder sphincter dysenergia patient. Urethral pressure profile measure using a catheter mounted transducer that is run slowly through the urethra by a motorized armature, can be performed in man or female, found to be helpful in assessment of women with obstructed voiding or urinary retention, some of whom may have abnormally high urethral pressure. Complication: urinary tract infection, hydronephrosis, vesico-ureteral reflex, renal and bladder calculi, renal deterioration, bladder malignancy. Thank you.
Once again, a very good morning to all of you. And again, wishing you all a very happy Diwali. I would request anybody, residents, faculty, or anybody who have joined us today, if they want to give their comments or any query, then please you can come in and give your comments. In the meantime, I would briefly summarize today's presentation that it was on pathophysiology and evaluation of neurogenic bladder. And then we will take up some questions and then followed by MCQs. You have MCQs, right? So first of all, the term neurogenic bladder is a misnomer, right? And now it is called neurogenic lower urinary tract dysfunction because it's not only due to bladder, but it is due to bladder, urethra, sphincter. So all these are responsible for the neurogenic lower urinary tract dysfunction. So that the term is neurogenic lower urinary tract dysfunction. When we talk about neurogenic lower urinary tract function, we should know the importance of the nerve supply of the bladder, urethra, and the sphincter. We all know the whole thing is due to disturbance in the central nervous system, the spinal cord, and the peripheral nerves. If there is any lesion, that would result in neurogenic lower urinary tract dysfunction. So we have a center in the pons, which is called the pontine micturition center, which is being regulated by the other centers in the brain, particularly the medial aspects of the frontal lobe, then the temporal lobe, then the cingulate gyrus, and the caudate lobe. So all these have been shown to kind of regulate the pontine micturition center. And now we have an investigation called resting state functional MRI that actually tells you which parts of the brain get functional when the bladder start filling up and the patient starts voiding. So that is very important, how the brain regulates the whole micturition cycle. And then from the pontine center, we have the spinal tract, where it goes up to the Onuf's nucleus, and then it goes through the pelvic plexus, through the peripheral nerves. We all know we have autonomic nervous system supply, which is sympathetic T9 to L2 and parasympathetic S2 to S4. And then we have somatic nerve system, which is S2 to S4. So these are important to know. Secondly, we must know how the neurogenic lower urinary tract dysfunction has been classified. There have been various classifications. Some of the earliest classifications were according to the lesion, whether this is a suprapontine lesion or it is a infrapontine and suprasacral lesion, and sacral or infrasacral lesion, or involvement of the peripheral nerves. So according to those, the classification was done, but most of the times the symptoms are quite mixed. So it could be upper motor neuron lesion, lower motor neuron, or it may be mixed of symptoms. So that was not very practical classification. Then we had Kumar classification, then Bradley's classification according to the neurological loops. And then we had Neurodynamic classification, then the International Continence Society classification, and the Lepidus classification. Lepidus, as he discussed, as a sensory neurogenic bladder, the motor paralytic neurogenic bladder, then the uninhibited neurogenic bladder, then we have a kind of automatic or reflexogenic neurobladder, and the autonomous or areflexic neurogenic bladder. And the simplest classification is by urodynamic system, when we say the bladder, whether this is normal, hyperactive, or hypoactive. Similarly, urethra, whether this is hyperactive, normal, or hypoactive. And similarly, sphincter, whether this is normal, hyperactive, or hypoactive. And then the sensation, whether it is normal, less, hyperactive, or less active. So this would be a kind of a very simple classification and a practical classification based on urodynamics. When we talk about evaluating a patient of neurogenic bladder, we all know we should know all the various causes of neurogenic bladder. They could be congenital causes, they may be acquired. In acquired, it can be traumatic, it could be inflammatory, it could be malignant, it could be traumatic. So the various lesions that can be produced by the various in various parts of the central nervous system and the peripheral nervous system, which can result in this dysfunction. And while going through the history, it is important to know again of the whole history of the patient. Then even the medical history, the drug history is important. There are various drugs which can also cause this lower unit tract dysfunction. Then while investigating this patient, definitely the urine routine and the renal function test and the serum electrolytes, all these are important. And then we do the various urodynamic studies, which could be classified as either non-invasive urodynamic studies or invasive where the patient is catheterized. So we all know the video urodynamics is the gold standard for diagnosing neurogenic lower unit tract dysfunction. And there are various non-invasive also, as it discussed about the uroflowmetry, the post-void residual urine volume measurement by bladder scanner, and the bladder weight measurement by, again, ultrasonography. So these are non-invasive methods. And then we have the standard, gold standard video urodynamic method to kind of evaluate a neurogenic bladder. I think this was in short about the brief summary of the evaluation and the pathophysiology of lower unit tract dysfunction. And we all know there is a term called neurogenic bladder also, where you do not get a particular neurological deficit, but it appears like a neurogenic bladder, which is mainly due to functional bladder problem of dysfunction. We must know while physical examination, we missed it. Physical examination is very important. Besides the examination of the abdomen and the local examination, the genitalia and the rectal examination and female vaginal examination, we need to have a focused neurological examination, which will tell you about the kind of a neurological deficit. So when doing neurological examination, we not only focus on the genitalia and the perineal region and that region, but we also need to see the lower limb neurogenic deficit. Because most of these patients who have a spinal lesion, they will have some lower limb neurological lesions, except the patients who have conus medullaris syndrome or the cauda equina syndrome, where you have a type of saddle analgesia and there is loss of sacral reflexes only, right? So you must know the various dermatomes which are supplied. The saddle anesthesia, where understand the term saddle, where so those areas which are covered by the saddle usually are lost by S2, S3, S4 lesion. So I think these things are important while doing a physical examination of these patients. So anybody has any query or any suggestion to make? Nachiket, and anybody has any? If you have anything, otherwise we will go ahead with the MCQs. So, which type of neurogenic bladder is characterized by bladder overactivity with sphincter underactivity? Hypertonic bladder, reflex bladder, retrosphincter dyssynergia, atonic bladder.
Reflex bladder.
Bladder overactivity with sphincter underactivity. Sphincter underactivity.
स्पिंडल तो टाइट होता है
हाँ तो उसमें डिसएनर्जी में तो टाइट होता है
फंक्शन करता है फिर रिफ्लेक्स ब्लैडर
Opposite action में काम
answer is C, dyssynergia. Okay. Occurs when bladder contracts, but the sphincter doesn't relax appropriately, leading to increased pressure and potential leakage. So what is it? Why did you say underactivity? With this
against each other. When the
Actually, resting stage में क्या है? Resting stage में the sphincter is already contracted.
Contracted.
It has to relax. And we think that जब spasm आएगा तो it will contract.
Yes.
But इसका जो normal resting phase में contraction नहीं रहता है, then it has to relax.
Right.
So C is the correct answer.
So which of the following is a common sign of bladder overactivity in neurogenic bladder patients? Urinary retention, infrequent urination, urgency and frequency, constant dribbling. Urgency and frequency, right? In patients with neurogenic bladder, what is the purpose of bladder diary recording? This we missed. It's very important. While taking the history of the patient, I always ask the patient to have a voiding diary because this is an objective assessment of the patient's own symptoms, which he might be missing.
Urinary pattern and symptoms.
So what is the purpose of? To track fluid intake, to monitor bladder habits, to assess urinary pattern and symptoms, to measure bladder pressure. C. So though we also in the voiding diary, we have bladder diary particularly, we also track the fluid intake. And so C is actually the answer, urinary patterns and symptoms. What is the most common cause of neurogenic bladder? Congenital abnormalities, spinal cord injury, aging, urinary tract infection. So spinal cord injury. Okay. So there could be congenital abnormalities also. Which congenital abnormality?
Sacroiliacosis. Meningomyelocele.
Right, spina bifida. I have spina bifida, which could be cystica, occulta, maybe associated with meningomyelocele. Yes?
Spinal disc.
Yeah, spinal dysraphism. What is that called? And the acquired causes, the most important spinal cord injury. So we must know the various, the lesion could be at various sites. One thing that you missed was a term called autonomous dysreflexia, which is very important while taking a history of the patients and while treating these patients. So any lesion above T6 can produce autonomous dysreflexia, which has to be treated immediately, right? We know there are various kind of precipitating factors which can result in this dysreflexia, and then we need to treat it with various measures, particularly nifedipine. What type of bladder dysfunction may occur in patients with upper motor neuron lesion? Flaccid bladder, overactive bladder, hypotonic bladder, overflowing incontinence. So overactive bladder, all right? So again, usually if there is a suprapontine lesion, it is mainly the storage symptoms. When there's a spinal lesion, infrapontine lesion, it is, and suprasacral, it is a mixture of voiding and storage symptoms. And if it is a sacral or infrasacral, then it is mainly voiding symptoms, right? So this has to be understood. What is a potential complication of chronic urinary retention in neurogenic bladder patients? Bladder cancer, stress incontinence, urinary tract infections, hematuria.
UTI.
UTI. So UTI, the stasis of the bladder will produce urinary tract infection. Yes. And it can produce then back pressure changes causing hydronephrosis bilateral, causing uremia, renal failure, and CKD. So all these are potential complications of chronic urinary retention. What type of urinary incontinence is most likely to occur with detrusor-sphincter dyssynergia?
Urgent incontinence.
Stress incontinence, urgent incontinence, overflow incontinence, functional incontinence.
Urgent incontinence.
Urgent incontinence. So we must know the various types of urinary incontinence, and we all know it could be stress urinary incontinence, urgent incontinence, overflow incontinence, functional incontinence. And while taking the history of the patients, is again important to know many of these patients, the treatment would be clean intermittent catheterization. And so one of the reasons for kind of incontinence could be functional problems, like the patient is aged and is not able to go to the toilet immediately. That is one of the reasons for incontinence. Similarly, we need to take a proper history about the functionality of their hands and the dexterity, which is again important. Because in the management part, we have to see whether the patient can do a CIC themselves or not. So while taking the history, it is important to understand the patient's functionality and dexterity. Right. So anybody has any query? I want, Nachiket, you want to give any comment? And Kuldeep, you want to make any comment? Otherwise, you.
Especially
Residents-
routine में they should not write very loosely. They write neurogenic bladder. They don't understand something. Something they don't have any clinical neurodynamic evidence.
Yeah.
Or a work of evidence.
Yeah.
That the patient has got features of neurogenic bladder. Then because this my only thing to the residents is that when you cannot label a neurogenic bladder, just lightly. There is something which is known as the first diagnosis syndrome, and what happens is that if you label a patient to be neurogenic, then subsequently, whenever the slip is going to be rotated amongst your colleagues or seniors, or even your other departments, then they'll always label the patient to be neurogenic. Every evidence has to be there that the patient is suffering from a neurogenic bladder, and there has to be either clinical, there has to be functional, or there have to be a urodynamic evidence. Then only will the patient be labeled as a neurogenic bladder. This is happen especially seniors also, and this is the first diagnosis syndrome is more engraved when a senior writes something like a neurogenic bladder. So every effort should be made to make to reach a diagnosis. If a proper urodynamic study, evaluation, and etc. they are done, then 90% of the times we are able to reach a diagnosis, and you're actually doing these patients benefit by not simply random and just putting them into category of neurogenic bladder. So very important point is that before making the diagnosis, you must confirm whether this is actually a neurogenic. And when you talk about neurogenic bladder, always write neurogenic lower unit tract dysfunction and not neurogenic bladder. So that term is misnomer, so don't write that. Again, always very important to understand the neurological deficits. You must do all the reflexes and the sensory tests, which are very important. You must know the various dermatomes, the various reflexes, which are important for the various nerves. Anybody else? Okay, for anybody from our audience, would you like to raise your hand and give some comment? Please let me know.
Hello.
Would you like to say anything?
Yeah. No, I think it's very nicely covered. I would like to best wishes and happy Diwali to all of you. There are two, three things which are the needed is especially the pediatric age group where the neurogenic bladder is very important, and especially you have mentioned about the bladder diary. That is important to know bladder bowel dysfunction. If there is a bowel dysfunction, there will be a bladder dysfunction. So this is one of the most important cause among the pediatric age group. Another one is that when we are evaluating the patients, especially of ureteric reimplant in a pediatric age group, where if somebody has dissected bladder more posteriorly, that is likely to lead to the bladder dysfunction. So these parts are important, especially reimplant patient persisting with the recurrent UTI or persistent UTI. These should be evaluated for the low dysfunction, neurogenic dysfunction. I must compliment and congratulate you for conducting it very nicely. Thank you very much.
Thank you, Dr. Bhatt, to making those observations very important. Number one, while taking the history, it's very important to take the bowel history also. And not only the bowel history, it's important to have a sexual history. Many of these patients who have a reflexogenic bladder may have reflexogenic erectile dysfunction. So may have sexual dysfunction in the form of erectile dysfunction or the ejaculatory dysfunction. And females can have some gynecological issues. So all these are very important while taking the history in a case of suspected neurogenic lower unit tract dysfunction. And secondly, the point that he made that many of these patients would have a vesico-ureteric reflux, particularly in pediatric age group. So when it's very important to understand that reimplanting the ureters in a neurogenic bladder is not a very easy thing. And the results may be very not very good. So in those, we actually need to, patients who need CIC, clean intermittent catheterization, we actually need to start the CIC and the treatment of neurogenic bladder first before reimplanting the ureters. so that the patient is compliant with the CIC before this surgery is done. And many of these patients may have problem after reimplantation because the bladder is not is thick and trabeculated bladder, and sometimes it may be difficult to reimplant. Yes, thank you. Anybody else? Anybody else, if they want to make any comment? Otherwise, we will wrap up the session. So I will ask the moderator, Dr. Kuldeep, to come and just give his last remarks, and we will end the session.
Good morning, everyone, and post Diwali sessions. Thank you, Ashok, and special thanks to our faculty, Dr. Shivam sir. Thank you, sir.
Thank you. Thank you. Again, I wish all those who might have joined us today on Zoom and YouTube a very, very happy Diwali, and happy Diwali to all of my residents and all the faculty members. Have a good day. Thank you.